Lovely friends you got that for birthday next year.
Did you see the baby with the fix? Who had the was it still at 3 0?
Yeah.
And there were just like the original
I think it's something to do with the heart. I don't know.
but it looked like the Tachycardia, but it wasn't like
It's on what?
and it was white.
Yeah.
I know what mine
I
is.
remember saying that they like
Oh,
it
yeah.
was bad enough that the
Yeah, I was in theatre.
So when I'm making notes on radiology, I try and don't reach.
Yeah, we got like
It's kind of fun to work
Yeah, look at mine.
In the same eye, it's like
behind it.
it's on the eye.
Oh yeah, okay.
Look
But
at
it's
it.
actually then you can't
They are shit.
things on.
I can read it.
Can
you read it? Can you actually read it?
You have
Yeah,
more
but he was
Yeah, I can.
But just struggling.
Not easily.
No, if I start with this baseline, imagine what like when I'm on a rickety.
You're on.
I've got time on one night shift.
That's really good. I think Austin is going like everyone's time.
Good? Really?
Yeah.
Are you Austin?
I heard that is what I think it is. Apparently
yeah?
medication that you prescribe.
I know medication for pathology and radiology.
Yeah, no, it's not drug.
Where'd you get it?
Yeah. No,
Yeah.
don't even
Yeah,
get
the
started.
buzzer.
Get her OCD.
Like.
You fax, you
Like,
can't
you
get
get
them
it?
to call to have the time to make sure you get them.
Whoa.
Wait. But when you get the result, they're online.
Yes.
So what happens
So you're gonna get
You get a bit of paper, you write your request, you go walk over to the
Not
fax
even,
machine.
like not even, because we have these, like.
No, there's like pro formas. Yeah,
So
there's
what if you, why don't you just send it to shoot? You check blood.
No, blood's fine, it's not radiology. Or
We have to take it down there. We have to go down there and make it.
Yeah, I want to.
No, we talking about that.
Is there 4 hospitals you have to beg for?
Yeah, it was great.
no, and like, they just won't do that, they're in the pub. So that's why you have to call and make sure.
You actually physically check it down.
I prefer that though, than faxing.
At least you know the dollar.
Yeah, you can fax it.
Faxing sucks. It's the only system.
Yeah, I was saying.
What kind of faxing is and then hospitals are
Revolutionary. It's actually like
I think it would not get lost.
Oh yeah.
Share the Google Doc.
Yeah.
Share it. Yeah, exactly. I got it. I think it's also very hard for safety. As in, once it's back, what they said, you can't track it anymore, if that makes sense. Like, it's not,
Okay guys, we get started.
Yeah.
So welcome to the second masterclass. The topic today is on rentals. So the venue usually is at ESJ King, but unfortunately we did have a double booking. So from now on we'll be back in the other theatre, ESJ King. And this is held every 2 weeks. So I'd like to welcome back Jason.
Woo.
Yay.
Yay, Jason.
Okay, so I got asked, first of all, is this working? Yeah, sure. Not for you guys, for the other people, I guess. I got asked to tell you guys why you should bother listening to me in the first place. To give you a bit of a background, I'm a second year resident that's working at the moment at the Austin. No, not in that respect, more just like, what do I know about met calls or anything. So I'm a second year surgical resident at the moment at the Austin, and I'll be joining the intensive care and emergency colleges next year as a registrar. And so I guess that's possibly some reason why this might make some sense to you, at least the heart rate stuff. Otherwise, I don't really think there's anything else too interesting to say. I guess we can get on with this talk. Unfortunately, we have to talk a little bit about ECGs, not too much because I hate them, but I find these 3 diagrams pretty useful. It's really important, obviously the one on the bottom right, to understand where all the leads are and what territories they're actually talking about. But there's no real point talking about an inferior MI if you don't actually know what coronary vessel it relates to. So everyone really knows inferior, that one seems to be pretty good, 2-3 AVF. The septal and anterior leads, everyone always gets confused, so you'll hear people talk about anteroseptal infarct, and it just means anything that's not inferior they call anteroseptal, okay? But in reality, septal infarct is looking at V1, V2, and anterior is looking at V3 and V4, and they're primarily looking at left anterior descending artery, or anterior interventricular, if you use the anatomy name, which is the big one that runs down between the 2 ventricles. The circumflex is going to give you your lateral ischemia, which is going to be your classically the 1 AVL and V6, the sort of diagonal pattern all the way across, and sometimes V5 as well. And they'll be pretty much your 3 main zones. So you've got inferior, anteroseptal, and lateral. The other quick thing that's probably worth mentioning, I got taught a mnemonic a while ago, PAILS, P-A-I-L-S. I haven't done this on the lecture notes, so it might be worth writing. And all it really does is it gives you a good idea if you have an MI somewhere where you can expect to see reciprocal ST depression. So if you have an anterior MI, the A in PAILS, the ST depression that's reciprocal should be in the inferior leads. So it sort of gives you a rough idea when you're looking at something, because sometimes you can see some really big territories that are infarcted, and like if you get left main sort of thing, although that's slightly different, so it'll give you a different syndrome. But if you get some really, really big infarcts, you can get a lot of ST depression in certain areas. If you know what leads you're looking for, you're not going to say something stupid, just like, oh, I think it's pericarditis because of a lot of ST depression, or something like that, okay? So not really necessarily clinically useful, but more useful for you. So we'll get on with the scenarios. So you're working on the wards, and you've got your stupid pager on you, and you get this page that just says, bed 13, fast heart rate, review immediately. And it's usually about that crap, right? So you go over to bed 13, and there's a 75-year-old female sitting in bed, comfortable with no pain. You don't know anything else about her at the moment. She's GCS 15, mentating well. Her heart rate is fluctuating somewhere between 115 and 140. They've got that little bedside monitor on that has a little pulse ox thing, and so it's going pretty quick. Her BP is 106 on 80, MAP of 87. JVP is not elevated, no peripheral edema and capillary fill less than 2 seconds. She's saturating okay, so that's stats of 95 on room air, good air entry, no creps, no wheeze, all that sort of crap. Soft non-tender, bowel sounds present, no IDC as usual on the ward, no one has one, so we don't know what her fluid balance is like. So I'm not sure how many of you guys were here or saw the last sort of lecture, but we sort of always want to look at, is someone well or unwell? That's the first thing you want to decide when you see a patient. So looking at this, does this look like a well or an unwell patient?
Well.
Why?
Because she's sitting up in bed comfortable with no pain.
Okay. Are you worried about the heart rate?
It's high.
Yep.
Yeah, and it's irregular.
Yep.
That's concerning me, but everything else at the moment seems to be under control. She's not going to rapidly deteriorate.
Okay. Yeah, I guess I can accept that, sure. So some of the things that I guess I really want you to look at, I've started putting the map in. I don't really think generally you'll get a map on the ward, just because the blood pressure cuffs that you do get, they do calculate a map, but whatever. And a lot of people on the ward don't really like a map, they prefer systolic blood pressure. So I prefer looking at the map, so I'll start putting it in there and at least talking to you about from that point of view, okay? But really what you're trying to look for is signs of shock. Anything that could mean that the patient isn't looking good. And it's not just that they're up and sitting well, even though conscious state is definitely one, but renal function, that's another big one, blood pressure's one, tissue perfusion, all those sorts of things. But you're right, she does look well. And that's her ECG. So anyone want to shout out what that is? AF, good. Why? Someone that answered AF.
No, naturally.
Yeah, good. So there's atrial activity, and there's seemingly no connection between the atrial activity and the ventricular activity, okay? Sometimes there might be some that go through, sometimes not, don't really know, but it's irregular, okay? We're all pretty comfortable with that. No tricks here, this is all pretty standard stuff, and it's what you'll see anyway, so you're right, it's AF. So the question now is, why? Why has she gone into AF? Does she have AF before? Does she not have AF? We don't know. We don't know anything about this patient. So when you go to someone and they have AF on the ward, this is a mnemonic that I tend to use because I like it, it's easy, And it sort of gives me the things that will have given someone a new AF if they didn't have one before. So PE, that's a big one. It can cause it just because essentially it causes problems with filling. You get right atrial enlargement, which then disrupts the pathway and you get AF. Infarction, so be it. Mitral regurg, essentially the same as a PE. Although again, not really typical that that's going to happen acutely, but it can. Anemia, yeah, alright, whatever. Toxins, thyrotoxicosis. Toxins more related to medications per se. Thyrotoxicosis, obviously hypothyroid is one of the big ones. Electrolytes and endocarditis. The electrolytes probably more important. Endocarditis, unlikely that it's really going to happen too often. And the specific electrolytes are magnesium and potassium. Why those ones, I don't know, but they're just the ones everyone's decided are the ones we look at. And the other one is sepsis. So that's the thing that you want to make sure. And again, a lot of these patients are going to be pretty sick and possibly septic, so make sure that you cover that off. And then of course the question comes to what do you do about it? So I don't want to teach you about AF because you'll come learn that from someone else, but really it's rate versus rhythm control is what everyone talks about, that catchphrase or something. What the hell do you do? Really for you all that matters is rate control. Don't worry about it. Doesn't matter if it's new, it doesn't matter if it's old, it doesn't matter if it's been there a minute, 10 hours, 400 days, or that's not really that long, but years or something, whatever. Just rate control. And really, to make it simple, the only way you want to rate control it is beta blockers. It's easy, okay? There can be some caution in someone that's got asthma and hasn't had a beta blocker before, and you can argue, yeah, sure. So maybe then you can use a calcium channel blocker, but really beta blockers. And it's pretty easy, grab metoprolol. Everyone knows it, the nurses are comfortable using it, and it's safe. Anywhere between 12.5 to 25, even up to 50 if it's someone that's on metoprolol before. But if you start with 25 milligrams of metoprolol orally, that will do well. Don't bother with IV stuff. You can do that in ED if you get someone in resus and they're pretty sick and one of the doctors says, I really, really want IV, but it doesn't really work that much better. It just works a little bit quicker, but she's stable at the moment, okay? And then of course the rhythm control medications, not that you will have to use them, but amiodarone is the one that you'll hear about. So when the Met call comes and when the ICU team arrives, they'll start amiodarone every time, okay? So while you're sort of sitting there working out what's going on, you work out that she's been in hospital for a small right-sided ischemic stroke a week ago. She's got chronic AF, she's on warfarin, mobilizing well with the physios. She's normally on metoprolol 25 BD, and her bloods in the morning showed those two with regard to the electrolytes. Hemoglobin was fine. So what do you think you want to do now? Again, no real trick. I sort of gave you the answer in the last few slides, so just shout out what I told you.
Rate.
Yeah, rate control. What are you going to give her?
See, she's had her metoprolol this morning.
Yeah, good. So let's say it's like the afternoon, because this is when it always happens. So she's had her metoprolol in the morning, but she hasn't had her nighttime dose yet because it's 6 in the afternoon. What are you going to do? Yeah, give her a nighttime dose. Yeah. Again, not really a trick, but just make sure that, give her the nighttime dose, pull it back, let the nurses know that to not give the nighttime dose, because this may well be very normal for her. If she's got AF chronically, it may be that she goes a little bit fast sometimes, but we don't monitor her at home, so we don't know about it. So just pull the nighttime dose back a little bit and go from there. Anything else there, like the only other numbers that I gave you that are on the screen? The magnesium and the potassium? Yep. So what are we going to do about that? Replace it? Did I hear someone say? Sure. And how are you going to replace it?
Well, the potassium isn't too low, so you give like some slow KSI and it'll rise a bit.
Good.
It's not, you don't have to do it drastically.
Good. Magnesium, is it low?
I'm not sure.
So generally, easy way to remember, it's K above 4, mag above 1. Okay? That's the sort of goal. Whenever anyone talks about electrolyte replacements for these sort of arrhythmias, it's a magnesium above 1 and a potassium above 4. And you're right about oral. So I would say that essentially because she can eat and drink and she's not unstable, there's no point giving her extra IV fluid at the moment, even though it's a small amount, like they're 10 millimole in 100 mils of saline. So if you're going to give a bag of each, it's only 200 mils. But you can also just make her have tablets, and it's a lot easier on the nurses. It leaves a cannula open in case she needs it for something else. Okay? Or you don't have to stab her, she's had a stroke, might not have a cannula. So I guess it's just worth thinking that there's no need, even though it's something that's relatively acute, there's no need to really go too full on at it and start with IV things, even though that's what we want to do. And so I heard someone say they wanted to send a troponin, which was great, really well done. And it comes back normal. Again, really, would you send a troponin once you work out she's got chronic AF? Probably not. But you'd be surprised at how many med regs would want you to send one anyway, so if they ask, just do it. You've optimised the electrolytes, you've given her some Magmin and Slow K or Corvescent. You gave her the night dose of metoprolol, and when you review in an hour, she's great, back to normal. Right? So that's the boring sort of AF. So let's say that we got that same initial page, bed 13, heart rate's fast, come review, and this is what you ended up seeing. So it's an 82-year-old guy's in bed. Oh, that sounds wrong with 3 nurses. Oh, 3 nurses around, that's okay. Yeah. He's GCS 13, so E3, V4, M6. He's just got his eyes closed and he's a little bit dazed, and when you yell at him, he sort of opens his eyes a little bit. His heart rate's 130 to 180, it's irregular. Blood pressure's 92 on 54. Cap refills 5 seconds, cold peripheries. He's saturating at 88% on 15 litres via Hudson. Rest rate of 24, course creps bilaterally. GIT is nothing important. He's got a catheter in, that's good, and he's got dark urine in the back. So is this guy well run? Yeah, good, okay. And what are some of the big things that jump out at you?
Altered conscious state.
Good, altered conscious state.
Renal and skin, like end organ shutdown.
Good, end organ perfusion problems, perfect, yeah.
Go through A, B, and C. So he's got low stats with a high rest rate
Yep.
on oxygen.
Yeah.
And then C as well, he's hypotensive with cool peripheries and on cap refill.
Yeah, perfect. So, yeah, essentially, I mean, you've got it all right, and it's all the same stuff, and you'll hear the same stuff week in, week out. So if you stop coming, I'll understand why. But really, it's all about trying to work out, do they have end organ misperfusion problems? The only sort of trap that I then tell people is make sure you don't always focus just on the blood pressure, because blood pressure is a great marker, but I guess we'll talk about in future sort of episodes. Blood pressure in itself is not actually measuring perfusion, it's just measuring a flow through a certain area. So it doesn't really tell you what's going on down the line, whether it's seen anything. So look for your other markers. The blood pressure being off makes you want to look further, and because you did look further, you found all these other things that tell you this person's sick. So, now that he's sick, what do we want to do? I think we've got an ECG. Yeah, there we go. So what's that? Yeah, well done. Yeah, it's AF, just a little bit faster. Yeah, exactly the same thing, right? So what do we do with someone that's sick and has AF? Yeah, exactly. So I guess this is all part of the ALS program. If you have any tachyarrhythmia, so any whatever, and it's got the patient has signs of adverse features. These are what they define as adverse features: shock, syncope, myocardial ischemia, and heart failure. Okay, but you can shock, because we're talking about that sort of poor tissue perfusion, essentially can mean what we just saw before. If you have that, they require immediate cardioversion. Now everyone gets worried with someone in AF because they say, what about the clots? And they've had it for ages, and are they anticoagulated and all that crap? It doesn't matter, okay? Not that you'll be the one that's doing it, because by the time you call for help and by the time someone else comes over, there'll be more senior people there. But quite frankly, someone's going to die a lot faster from blood not going to their brain than from potentially a thrombus that could be somewhere flicking off and giving them a small infarct. So if they've got signs of these adverse features, you've got to prepare to shock. So the things that you'll be doing, again, that's the theory, that's the advanced sort of stuff, if you want to call it that. But what you, in doing reality, you get there, you see that patient, and you sort of say, why the fuck hasn't a Met call been called, because this patient's sick? And you get someone to call a Met call. Then you go through ABCs. It's really that simple. I've just made something up here. So someone's at the airway doing simple maneuvers. Simple maneuvers being, if he's a little bit sort of GCS 13, so it's a little bit out of it, you could probably get away with doing like the jaw lift, you know, chin tilt, or is it chin lift, jaw thrust, head tilt, that sort of, that 3-step maneuver sort of thing. And if you've ever done it on someone, you'll know exactly how poor their conscious state is, because if you go sort of to their head and you put your fingers right behind their jaw, you put your palms on their face, on their maxilla, you put your fingers behind their jaw and you squeeze together and it just lifts the whole jaw off. And if they tolerate that, they're in really bad state, okay? But you can get someone there trying to help. You can give them oxygen. You've already got a Hudson mask on, but you can put a rebreather on as well, because that then gives them at least another litre of sort of, fully oxygenated sort of oxygen, I guess, that they can breathe in. And you want to support their blood pressure, because they are hypotensive. So again, you'll probably hear of things about, heart failure, and you don't want to give too much fluid and stuff. You can always safely give 500 ml of fluid, and that's being conservative. I've had the ICU consultants that say you can give 2 litres of fluid IV. Now, I'm not sure I would do that as a straight up thing, but the point is that you don't have to be scared of a little bit of fluid. So in this person, you grab a litre bag, hang it up, make sure you've got IV access, of course, 2 large bore cannula, that sort of thing, and you start the fluid running. And you get the nurse to set it to a 2-hour bag, because that means that it's an hour, 500 ml, that's like the stat, 1 hour sort of thing. The other things that are going to be important for this, because we know we're going to be shocking someone, is you ask a nurse to go and get some fentanyl, you ask a nurse to go and get some phenylephrine or some adrenaline if they've got some, and you ask for amiodarone. And the reason for those, the fentanyl, is because when you shock someone, it really hurts, and they will not like you for doing it. So you want to give them some sort of analgesia. It's a short-acting analgesic agent. It's pretty good for them, like even if they've got some sort of chronic kidney disease, so that's a good one, okay? The phenylephrine and adrenaline, we've already sort of touched on the fact that blood pressure in itself isn't really a good marker for perfusion, and this is only going to really vasoconstrict, so it's going to make your perfusion even worse in the short term to give you an arbitrary lift in your blood pressure number. But the reason you do that is you want to have it there for if the DC cardioversion doesn't work, which it never does, and you have to start on the amiodarone. You don't want to run amiodarone over the actual 20 minutes to 30 minutes that you normally do. You want to do it faster. So, because it's going to give you a rebound hypotension, you've got the push dose pressors there to be able to keep their blood pressure up and keep their brain perfusing. Now, like I said, this isn't something that you'll necessarily do, but if you've got it there and thought of it, you'll look a hell of a lot better, and it will aid in everything else. And I guess the last thing you want to do is actually prepare the person. So they're going to get shocked. Get them flat in the bed, take their top off them. If it's a guy and he's got a hairy chest, shave it, because the pads need to have really, really good contact with the skin, okay? So the MET team arrives, they try their synchronized DC cardioversion, and it doesn't work. They try 100, 150, 200. They start him on the amiodarone infusion, 10 minutes, and they use the push dose pressors to keep the blood pressure up. And this is always about the stage where everything's sort of starting to slow down and you're standing there, and the reg will be like, all right, why don't you go now and do some work? So you've gone and done work, and you hear later on that the patient's fine. And that's just my way of wrapping up that little scenario. But in reality, it's what happens. So really, you're useful to be the first person there, and then you're useful to get out of the way and get on with the rest of the jobs once that's done. But let's say, we didn't see that. Let's say we get this other pager instead. And this nurse is a bit nicer. She sort of wants to talk. So this is hi. There's a young girl in 70s, bed 14 with a fast heart rate. Very anxious. Please come review. And she even says thank you. So that's nice. So we go and have a look at this patient. Young girl, admitted post a fall from a horse. It was a trauma call in ED, so they've got to keep her in for 24 hours for the tertiary survey. She's sitting in bed. She's a little bit anxious, otherwise well looking. She's tachycardic, heart rate 140, blood pressure looks pretty good. All the other stuff in there looks pretty good. Calves are soft, non-tender, slightly dry, you might say. She's saturating okay. She's slightly tachypnic, but maybe it's just because she's anxious, who knows. No cramps, no wheeze, no pleuritic chest pain, abdo's fine, no IDC. Is she well or is she unwell?
Wow.
Wow.
Good. I'm not even going to bother asking why. What does that show? Sorry? Yeah, sinus tachycardia. Good. Why?
Tachycardia because it's fast.
Yeah.
It's sinus because there's a P for the QRS and the QRS
Yeah.
for every P.
Yeah, perfect. Honestly, it's that simple. The only reason I put this in here is because it's really, really important. Two things. First of all, to recognize that sinus tachycardia does occur. So not everything has to be like the really awesome AVNRT or something, or AF with rapid ventricular rate. It can be just a normal sinus tachy. Sometimes though, as they get fast, they can actually be quite difficult to distinguish from SVT, from other forms of SVT, mind you. So one of the things that they sometimes say is that you can have a characteristic camel hump. Essentially you get the P wave that gets hidden in the previous T wave, and so you get like a non-complete T wave before the P starts. It's pretty much that simple. But it's something that will only happen really in the sinus tachycardia at higher rates. There are some causes you have to look for. So the most common ones in most of our hospital patients are going to be probably the first two, hypovolemia and pain. That will, if you manage those, you're probably going to fix a sinus tach. There are some of these other ones, anxiety, hypoxia, hyperkalaemia, hypercardia, whatever you want to call it, acidemia, sepsis, PE, hypothyroidism. Yeah, sure, you send off a few things to look for those. But really the first two are the ones that you want to go for. And the only other word of caution is to treat the underlying cause. So the heart rate in itself is physiological and it's normal. So if you try and slow the heart rate because you're worried about it or because you want the nurse to stop paging you, you're going to do damage to the patient. So don't give them the beta blocker that we gave before. That's all we're saying. Okay? And just in case anyone didn't see the camel hump, you can see in lead 2 right down the bottom of the rhythm strip that you don't get the return to baseline, the isoelectric line after the T wave. So that's sort of the camel hump that they're talking about. So she's a young girl, she's in the trauma. We said she was possibly a little bit dry, so we gave her a bag of CSL. Asked her to increase oral intake. Now there's a debate about whether or not you need to give IV fluids or whether you can just have oral fluids. The truth is, if you've got someone that's in sinus tachycardia like that, why not give them IV fluids? Like, she's in here, she's got a cannula, it's not going to make a difference. You can tell her to drink, but if you try drinking like 2 litres of water, what's it going to do? Like, it's going to be difficult. So give her a litre and tell her to drink. She'll drink the 1 litre over the next 5 hours, and she'll have another one that goes straight into intravascular space immediately. Okay? You can help calm her down, non-pharmacological ways first, which is sitting by the bed and just being like, it's all okay, you're not going to die. And then you can also chart 5 milligrams of diaz for when you leave and you don't want that to get paged again for no reason. You check her bloods to look for all the other non-common causes. So you make sure that there's no inflammatory response that's going on, no marked leukocytosis, nothing else that's being missed. You check, we've already checked her calves, that was fine. She's not in pain, even though she was in a bit of a trauma, but that's fine, she's not in pain, so that's all good. We've added on a TSH and a free T3 and T4 just because we could, and that was normal. And then when we reviewed her in 1 hour, the sinus tach had started to reduce, okay? Which it will reduce quite quickly once you start getting fluid. Not perfect, not all the way, but you know, it's good enough. So that's the boring sort of tachycardia. This is the other one that you see, which is where you go to this same young girl and she's sitting in bed and she looks nervous. She says she can feel her chest thumping like her heart's trying to jump out of it. She's mentating well. Heart rate's 160. BP, it's okay. JVP's not elevated. Cap refill's good. Warm peripheries. She's saturating okay. Good air entry. No chest pain. Abdo soft, non-tender. No fluid balance as usual. So does she look well or unwell? Sorry?
Well.
Yeah, good. She does. She looks well. So, again, I guess I put this sort of half-well looking patient here because I don't want you to think it's going well and well, well and well, and make it easy for you. So yeah, look at it. She looks well. Yeah, she's got a heart that's thumping and going crazy, but she looks well. She's stable at the moment, right? And that's her ECG. Anyone want to take a guess?
Tachycardia.
Good. Let's start with the easy things. When it doesn't jump out, you start with the things you know.
Tachycardia?
Yeah.
I can't discern any P waves for QRS, but the QRS complex is narrow.
Yep.
And so it would be supraventricular tachycardia.
Good.
And it's regular, so it's unlikely to be AF.
Yep.
It's not a sawtooth pattern, so it's unlikely to be atrial fibrillation, and therefore...
You mean atrial fibrillation, sure.
Sorry, yeah.
Yep, good.
So therefore it's likely to be a re-entrant supraventricular tachycardia.
Perfect. That's really, really good. And I'm very glad. I thought someone was going to be able to trip someone up, but unfortunately I couldn't. Because I thought someone was going to say, oh, it's SVT. And I guess you guys will learn more about it than I did at your stage. Just to distinguish, because you'll hear it a lot in the hospital, that SVT in itself is not a specific type of rhythm, okay? SVT is a group of rhythms, and all it refers to is a supraventricular source. It's anything above the bundle of His that causes the tachycardia is a supraventricular tachycardia, okay? You can break it up into regular, or irregular, or you can break it up by the origin. I prefer the regular versus irregular because it makes it pretty easy. So your regular runs a sinus tach, your flutter, AVRTs, AVNRTs, and junctional tachycardias. The irregular is AF, flutter again, but with a variable block, or when you get MATs, multifocal atrial tachycardias. Okay. Now the other thing is that these can be quite difficult to distinguish on ECG. So it's not necessary for you to really be able to diagnose which one it is. As long as you have a rough idea, like that was fantastic. Went through the ECG, it's a supraventricular tachycardia and she's stable. So there are some things that we can try doing. Now you try and work out what sort of SVT it is. So the trick in this one here, the ones that you'll probably want to distinguish between are a flutter with 2-to-1 block, which gives you that underlying sawtooth pattern that can be pretty difficult to distinguish, between an AV-NRT and an AV-RT. The difference between those is that the AV nodal reentry is what we commonly misrefer to as an SVT. So that's when there's the aberrant pathway within the AV node, there's a slow pathway, a fast pathway, and the electrical impulse gets caught up in it because the fast fibers will actually come back before the slow fiber pathway has gone all the way around. So that is a functional, an electrical tachycardia. An AV-RT, an atrioventricular reentry, is actually a pathway, a physical, anatomical, functional pathway. So it's got nothing necessarily to do with an aberrant electrical pathway, okay? It's a physical thing. And I think the trick in this one here, so if you look at V2 and V1, if you look just after the, I can't reach that, so I can't go up to the board unfortunately, but if you look just after the QRS complex in V1, there's a little upward spike. I wonder if I can use a mouse. Oh yeah, look at that. So there's a little upward spike just there. You see that? Maybe? And there's a little one just there. It might be hard to see on the big board. So those little upward spikes are actually a retrograde conduction from the AV-NRT that goes backwards and gives you a P wave. So, because that's essentially what's happening in the little conduction system. It's going back through and re-exciting the atrium, but it does it in such a way that it gives you what they call an pseudo R prime wave, which is that little R wave after the QRS complex. And it's most notable in V1 and V2 for these. Again, if you really see that, I'll be super impressed, like on the wall. It's a tachycardia, all right? So we've got a stable AV-NRT, or is AV-NRT / flutter / whatever else we think it is. So we do our usual non-pharmacological things, vagal maneuvers, carotid sinus massage. Please be cautious with carotid sinus massage because, like, you'll laugh about it, but people do stroke patients out by pressing the carotid artery, and then all of a sudden they're like, they walk out drippy face and can't walk. So it does actually happen, okay? And it's not that, it doesn't really work that well. So it's not worth risking in someone that's old. Someone that's young like this, yeah, sure, go for it. Like, she's not gonna have any atherosclerosis. But anyone really over the age of that 55 to 60, I'd be cautious in doing that. Now the vagal maneuvers, I'm not sure if I talked about exactly how to do it. So the vagal maneuver, yeah, essentially you get a syringe, a 20 ml syringe. You tell them that they have to make a really, really tight seal around the syringe with their mouth and they have to try and blow and make the syringe open up, okay? It never works, primarily because they never do it properly. They just all around the place and you're like, oh, well, that's not really working. But it's worth doing and it's worth trying, and more than that, it's worth at least making a note of so that you can then convince the nursing staff that the next step is going to have to be adenosine. And the reason you have to convince them that you've tried everything else is because when you do this, you have to then do a little bit more work. So the pharmacologic reversal for an AV-NRT is adenosine, 6 milligrams, then 12 is the way that you try and do it. You need to give it through a good peripheral IV, so you make sure you've got that access. And because of the way the medication works and because it's such a short-acting thing, when you do it, you push it really, really, really fast through this big IV, and you've got a big 20 ml syringe of saline afterwards, or 40, or even more, and you just push them through as quickly as you can afterwards, okay? You'll see the effects really quickly. If it doesn't work, you try it again in another 1 or 2 minutes with that sort of dosing increment. And the other thing to tell patients is that they are going to feel like shit. They will really, really feel bad. They'll feel like they're going to die. It's one of the worst feelings ever. But you also tell them that it passes in about 2 seconds, okay? But if you don't tell them, it's like they really, really don't like it. So, we tried the vagal maneuvers and the carotid sinus massage and it didn't work. We called the Met team because all of this stuff then has to be done under more controlled scenarios. So you make sure you've got the defib pads on, you make sure you're monitoring in case anything goes wrong. We got ready for the resuscitation. We gave 6 milligrams of adenosine with the flush afterwards. And then you see this. So the only reason I really put that up there is to let you know that that's normal. When you give someone adenosine, you watch the screen, and I know the first time I gave it, I was expecting like, you know, a little short bit of asystole, like half a second or a second or something, and then go into sinus. And it lasts forever. And whenever you're watching, it always feels like it's a lot longer. And you're sort of looking at them like, should I jump on their chest now or something? But just be prepared. It's going to give them a good going asystole that could last up to 10 seconds sometimes, which is a hell of a long time when you're watching a monitor. And then it will go into sinus. If it doesn't, and if they lose output, then you've got to start your CPR, which is why we end up attaching to defibs and getting everything ready early, because you go into PCLS mode. Doesn't happen that often, unless you've misdiagnosed in the first place, which is something we'll have to talk about, I guess. But that's what you expect to see. So she reverts to sinus, doesn't require any resuscitation, which is good. And she's someone that will then need prophylactic medications. Again, it's not something you need to worry about, but if you sort of mention it, it'll be pretty good to the registrar. You're like, oh, we should start on some sotalol, shouldn't we? Before, and you're like, oh, that's fucking good. And if they ask why, it's because sotalol in particular is a beta blocker that also has some class 3 antiarrhythmic agent properties, okay? That's why sotalol, not metoprolol or something else. Does anyone recognize the one up the top, the ECG up the top? It's an eponymous syndrome. Yeah, Wolff-Parkinson-White. So this was the caution. Wolff-Parkinson-White syndrome, it's one of the AVRT, so it's a congenital physical pathway. The characteristic delta wave is what gives it away. And we'll go back and have a look at the ECG. The caution is when you have Wolff-Parkinson-White with AF. If you give these people adenosine, or a beta blocker, or a calcium channel blocker, they're more likely to go into VT or VF, and it won't fix their problem. So what you do is you treat those people as a stable VT, which involves synchronized DC cardioversion and a different set of ACLS pathway. The only reason I really put this up, and the reason I say caution sort of, is because, so that's Wolff-Parkinson-White at the top. And in case anyone didn't see, this is that delta wave. So it's that widened QRS complex. It's on the first side, it's just after the P wave, and it sort of gives you that sort of quick tail up, or like a wing, delta, I guess, half a delta. That at the bottom is Wolff-Parkinson-White with AF. So when you look at that, if you don't really think at a quick glance that that's VT, and you want to try doing a vagal maneuver on that, and giving someone adenosine on that, I really don't think you're in the right career path at the moment, okay? So that's why I say caution sort of. Yes, you can do damage, of course, but that's what WPW and AF looks like. So you should be thinking of something else, okay?
How do you know that?
One, because I Googled it,
yeah,
so I know that that's what I put up the image. Second, because as opposed to how do you know it's not VT?
Yeah.
So
that and say
it is. It's tough to work out that it's not VT, primarily because you can see that there's differences in the in the width of each QRS complex, so it's not a stable thing. Ventricular tachycardia more often has a stable thing. Polymorphic VT is another thing. However, when you get polymorphic VT, what you tend to get is not necessarily differences in the widening of the QRS complex, but also fluctuating their voltages. So you can also argue that there's some evidence of delta waves, and there was some, where was there? Over here, that doesn't look like a primarily ventricular sort of beat. So again, how? It's really difficult, but you're right, that's why you say it's VT. And you call someone, and then the ICU reg comes over, and he's like, oh, I think it's VT too. And you shock it, and then it's only afterwards when you've cardioverted them, you get the rhythm up, the ECG up top, and you're like, fuck, was that actually Wolff-Parkinson's-White? And that's what happens, okay? Just don't give them adenosine. That's the moral to the story.
So it doesn't matter because it looks like VT.
Yeah, exactly. And you treat it like VT. So it actually doesn't matter. But you know, for the in the theoretical world, to make yourself look good, those are some of the reasons why. So this is the next scenario we've got. Hi, Fazio, this is the patient's last name, I guess. Room 31 is a fast heart rate, please review. So he's a 78-year-old guy, we know he's admitted with pneumonia, we get that on the walkover. Sitting in bed, he's looking a little distressed and nervous. GCS 15, he's tachycardic 150, hemodynamically stable, capillary fills 3, moist mucous membranes, saturated okay on 2 litres. He's got right lower zone creps. Just another note, I'm sure maybe you guys already know, when you listen to someone, don't tell me that they've got right lower low creps or right middle low, because you can't hear a right middle low. You can identify zones, okay? Small thing, but when you hear it, someone says, you're like, oh fuck, really? So, zones. Oh, is he healthy or is he good or like well or unwell? Well, yeah. So even though he needs a little bit of oxygen, he's got pneumonia, that's okay. Capillary fill times 3 seconds, 3, 2, alright, sure, whatever. So he's well. And that's his ECG. A bit small, isn't it? Anyone want to take a guess? Given I just talked about other SVTs that you might want to give adenosine to and to have a look at. Is it flutter? Yeah. Yeah, flutter with a 2-to-1 block. So that's a pretty obvious one at this point. This is a great ECG for it, because I searched it. But, and you can see it's quite clearly got the flutter waves in it. Obviously, the way to help distinguish between a flutter and something else, there are some signs you can look for. So in terms of what the flutter is, it's one of the re-entry pathways. It's a structural thing. Commonly, it actually occurs around the IVC and the tricuspid septal valve, so around the actual AV nodal area within the myocardium. 90% of the time, it's in an anti-clockwise fashion. All that really means is you'll see inverted flutter waves in the inferior leads, which is why people will often say, if you have somebody you think has a flutter, you grab the ECG, you turn it upside down, and you look at the inferior leads. Because when they're upside down, then you'll actually see the flutter waves in the right way up, and it just works better for us. Okay? 90% of the time that'll work. The other 10%, you'll see them the right way up the first time around. And all these will be up on the web as well, these notes, so you don't have to write like crazy. I think we've seen that, the flutter waves. So the treatment's similar to AF, that's fine, we all know that, and it's nothing really you care about. I guess the important thing from our point of view is because you're not often sure if it's actually a flutter with a 2-to-1 block or if it's an SVT, one of the other SVTs, the AVNRT, sorry, you can use adenosine to unmask the flutter. And when you do, it essentially gives you the asystole, but with the flutter pattern in the background. So you still crap yourself because they've lost ventricular output, but at least you know it's flutter, so you know that, hopefully, it should come back in a minute, well, less than a minute, but yeah, they'll get their output again soon. Once you know it's flutter, you can treat it differently. Surprise, surprise, we called for a resus trolley, we gave the adenosine, we unmasked the flutter. The tachycardia came back because it's flutter with 2-to-1 block. We gave him a toprolol, which has worked slightly in rate controlling, and it's someone else's problem, cardiology. Now this is the other one. So we talked a lot about the fast heart rates. Now we get one of the slow heart rates, which are far less common, mind you. So bed 6, Thompson has a new slow heart rate. The registrar's not answering. Please review immediately. So he's a 68-year-old guy who's admitted for acute coronary syndrome. He's lying in bed, drowsy. GCS 10, E2M4 V4. Heart rate's 37, so it's a good going bradycardia. Hemodynamics aren't that great either. He's got pretty poor tissue perfusion. He's not saturating very well. His abdo looks okay, that's good. And we don't know about his kidneys. So, looks pretty unwell. I guess I don't have to ask. So this falls into the bradycardia with adverse features side of things. So it's the same sort of adverse features as before that we had for the tachycardia: shock, syncope, myocardial ischemia, heart failure. What you want to do this time is almost the same as last time. You met call or code blue because this is like a peri-arrest rhythm. You do your ABCs, which I don't really think we've got down here. But the difference is that whereas before we had the fast heart rate that we were trying to make go slow, now obviously we've got the reverse, the slow one that we're trying to make go fast. So what you ask for is atropine. Now the reason it's 500 to 600 should be micrograms, not milligrams, so please don't give 600 milligrams of atropine. The reason that we've got 5 to 600 is only because some hospitals stock 500 or 600 in there as their go-to number, okay? So it's whatever the hospital stocks. And you can give it every 3 to 5 minutes up to a 3 milligram dose. You ask the nurse to go and get calcium chloride. We talked about that last week with the hyperkalaemia. The reason is that it's also got positive inotropic effects. Directly related to that, I guess, is that part of the potential cause for your bradyarrhythmia in this case could be drug toxicity. The common ones in hospital are beta blockers and calcium channel blockers. And I know it might sound ridiculous, but you'd be surprised at how many times at a nursing handover, afterwards, someone will come up to you and say, I'm really sorry, but I just gave another 50 of metoprolol, and the nurse told me that she did it, but she didn't sign off, so he's now at 100 of metoprolol. And you're like, oh great, cool, that's awesome, good. The way to fix that is glucagon, but it's not something that you do. So if you ask for it, that's great, it'll look really good. But calcium will help with the calcium channel blocker overdose, and it will help with the inotropy anyway to try and counteract some of the beta blockade that they've just done because of that. And of course you prepare for the transcutaneous pacing. So one nurse initiates the MET call, you attend to the ABCs. The MET team arrives, just as the nurse has brought back that syringe of atropine, which is good. You give the 500 micrograms with all the leads in place. Heart rate goes up a little bit. Sometimes you actually get a rebound bradycardia immediately as well, so it's something to watch out for. You give the atropine, but it actually gets worse for like 5 to 10 seconds, and then it starts to pick up again, okay? It doesn't really work, patient's still shocked. You finally got your ECG leads in place, and that's what you get back. So I know it's pretty obvious, but someone yell it out for me. Where? Okay, be mindful, this is a bit of a confusing ECG just because they've got 3 rhythm strips.
Yeah.
So these are your leads.
Yeah.
So where is it?
It's 2, 3, AVF,
With reciprocal chambers.
laterally and AVL, and yeah, I'm not sure about the other lateral leads.
Yeah, it's difficult because whoever did this ECG, obviously the person started moving a fair bit or whatever, but
Yeah.
you're right. So it's primarily a massive inferior STEMI, massive inferior STEMI. Are there some, I heard someone say reciprocal changes and someone say that it's actually in AVL. Look, it could be a little bit of both. Difficult as well because AVL is obviously the distal territory of the circumflex. So at the back, circumflex actually anastomoses with right coronary, so a big inferior can actually sometimes leak into AVL if the right coronary actually goes a little bit further and provides that area. So it can be really difficult, but primarily we're looking at a massive inferior MI, STEMI to be more precise. Anything else that's interesting about this ECG? Sorry? What else do you look at in ECGs after you've worked out QRS and ST? What's some of the other things?
Bradycardia.
Yeah. What sort of bradycardia is it?
Heart block.
Yeah, good.
Because P waves are not actually the QRS.
Yeah, what sort of heart block?
I'm not sure.
Sorry?
3rd degree.
3rd degree, did you say? Good. Yes. 3rd degree heart block. So remember there's type 1 PR prolongation, type 2 which is broken up into class 1 or subtype 1 and 2. The first one's called wanky back and I have no fucking idea why it pisses me off, but so be it. So you've got your 2A, which is your progressive prolongation and drop beat. 2B, which is when you have you can get the different ones like the actual rhythm blocks, like a 3-to-1 block, 2-to-1 block. And then you've got your complete, which is where there's total dissociation. The interesting thing here is that even though there's total dissociation, there must be something this actually has a junctional tachyventricular beat because it's not really a widened QRS, so it's not further down the system, it's coming from essentially at the AV mode. But you're right, it's a complete heart block, P waves totally dissociated with the QRS, can't tell the difference, right? And we know it's common with an inferior MI, because 90% of the time, right coronary supply is an AV node, so you're likely to get that total dissociation, okay? Now, unfortunately, this guy gets taken over by a CU in cardiology. He goes to the cath lab, he arrests on the table, and they can't resuscitate him, which is not, unfortunately, that uncommon. So when you see these sorts of things, don't necessarily feel like you've done anything wrong if they end up dying, because really, like, what the hell are you going to do about that? They can try, but you've done your job. You got the atropine. You got the yeah, you can give some aspirin, sure.
GTN.
So the only other thing to mention, I think that's the end of the talk. Assuming he didn't have massive ST elevation, so he didn't get rushed to cath lab. The only other thing to mention is that you can do transcutaneous pacing on these people. If you're going to do transcutaneous pacing, similar to when you do the DC cardio version from before, bring some sort of analgesia, because having been zapped every like 60 seconds to pace really hurts, and they won't tolerate, they'll pull it off, and then you haven't done anything. The transcutaneous pacing is only your stopgap to get to transvenous pacing, and then after that, your stopgap to get to fixing the problem. Doesn't make much of a difference, but if you mention it, again, you look pretty good.
What's the analgesia choice, considering fentanyl's got quite a short half-life?
So the thing is that it does have a short half-life, so having said that, you're not going to be necessarily pacing them hopefully for too long. Like to get a central venous pacing, you have to get a central lining. Once they identify it, once you've got it, it can happen in sort of 10-15 minutes. You can do push dose, or you can start infusions. If you start infusions, do what you want. Fentanyl, morphine, ketamine is fine. If you want to do push dose, again, fentanyl, morphine, probably wouldn't do ketamine push dose. You can, just give small ones, but why bother? I prefer fentanyl only because it has a shorter half-life, so it also then makes sure that someone is always there by the bedside if they're going to do push dose, which is often what you're going to do. And it's got less toxicity. It relies less on other organs needing to work to both metabolize and clear it afterwards. So personally, I prefer fentanyl, but morphine's fine as well. Any other questions? Nope. Alright. Anything else that you guys have worries about that you want me to try and cover in the next few weeks, a few fortnights? You know, that. No, we're pretty comfortable, that's good.
Well, it's just not one single thing. On
Yeah,
I know. You can't pinpoint like what the
medicine?
Yeah, okay.
All of it.
All of it. No, look, like if there's anything specific that you're worried about, any certain topics that you're worried about, I guess what I'm trying to go through is the resuscitation side of things, just because that's what concerned me the most, and because that's what you don't have time to decide about. So I guess that's why I prefer talking about it and why I was really worried about it. But if you guys are worried about anything else, I'll talk about trauma later on, and we'll do a talk on that. If you're, I don't know, whatever, pick something. If you really want to know about how to survive as an intern or the non-medical stuff, I'm happy to talk about that as well.
Did you say you're doing dyspnea next week?
Sorry?
Are you doing shortness of breath?
Yeah, so next week will be sort of the other side of the neck calls. So some of the blood pressure, now that we also have the heart rate, we can do that, and some of the respiratory distress problems.
Great. Sounds good. Thank you.
No worries.
This is saying.
Just
Oh, I think that's.
Sorry.